is a springtime rain to have a friend right in your corner. Your heart will feel a little warmer. Tender loving care, tender loving care. Each warm and friendly touch lets someone know you care so much. Tender loving care, tender loving care.
Good evening, I'm Dr. Greenbrier Almond, and thank you for joining us on our program, Tender Loving Care. Each week on Channel 3, I'm happy to talk about this interface between Christianity and medicine. And tonight I'm going to be talking about an article that will describe that interface more, that has been written by our daughter Maria Almond, who is a physician, who's the director of the Psychiatry Oncology program at the University of Michigan in Ann Arbor, Michigan. And we're very proud of Maria. Very proud that she has written an article that is in the June issue of Current Psychiatry. This is available. You may go online, currentpsychiatry.com, and this will be out. You can see the banner through the program. The June volume 12, number 6, June 2013, Current Psychiatry. Maria's taken a topic that all of us have experienced one time and another, and has tried to give a medical school lecture or a doctor's lecture to doctors who would read this for continuing medical education. But I thought it has a broad appeal, and of course as a dad I want to brag on Maria. Her topic is about inflammation and depression. Now all of us have experienced something like this. We get an infection, a sore throat, an earache, a bellyache, something like that, and we feel bad. We have a fever, we have malaise, and we ache. Maybe the throat is sore, maybe the tooth is sore, belly aches. But more than that, we feel depressed. We don't have energy. We feel blah. We can hardly motivate. We just want to go to bed. We feel miserable. And if you take it away from the inflammation part, a lot of the signs that are described by people who feel bad when they have an inflammation are similar to how people feel who are depressed. And likewise, many people who are getting a severe illness, a cancer, some 25% of the time, or maybe a heart disease, or maybe multiple sclerosis, fibromyalgia, rheumatoid arthritis, you go on and on and on, diabetes even, the prodrome period, the period leading up to the active disease, the diagnosis by the doctor, has a lot of symptoms of depression. And this is an important area to study. As Maria talks about in her article, and we're going to go into this in some detail in a minute, but I just want to paint the big picture for you. As Maria goes into this, she's describing instances where people have recognized this fact that you can take sometimes a medicine like an aspirin with an antidepressant, and the antidepressant will work faster in some cases, not every case. You may take an antiviral medicine because you have a virus, maybe HIV, it would be a severe viral illness, or you may have something more minor than that and take like hepatitis C. It's not really minor, but it's not always life-threatening. But you treat that with interferon or a medicine like that would involve the liver. And if you add an antidepressant, then those medicines that you use to treat the infection work better. And so see, the trade-off is back and forth. And so this intrigued Maria, probably in her work with patients who have cancer there in Michigan, the University of Michigan, and she's looked at this interface between depression and inflammation. And of course, now, to complete the circle here, because we're talking about the body, the mind, and the soul on our program, people who are depressed feel like they have committed the unpardonable sin. They feel horrible. They feel God has forsaken them. They feel that they cannot, they're not worthy. They can't be redeemed. And of course, the end result of that, if it goes down the path too far, is suicide. People give up. And indeed, then that does raise a question. How does God deal with that? Of course, God is God, but how does he deal with someone who takes their own life, self-murder? This is a debate that I go through with my patients. I listen to my patients, but they go through the process of trying to figure out what to do with their depression and how to treat it. And of course, not wanting to give up, but the thought comes to them and say, I maybe I'll give up. People who have cancer, severe pain, we know that they can get help with pain medicine. We know that the pain medicines are highly effective, but you know, there's debate. Out in Oregon is a state, the Netherlands is a nation. There are places in the world where there's doctor-assisted suicide. Patients have a life-threatening illness, illness for which they're going to die, and the doctor assists them in their depression to kill themselves, to take a large amount of medicine and to stop breathing and to die. And this is a dilemma that doctors face and patients face. So Maria's topic is quite important, I think, to look at. So she begins, and I just want to reiterate this because it's cute, the way she starts. The sneezing, coughing, sore throat are the hallmark symptoms of the common cold. But how about the fatigue, the inattentiveness, the loss of appetite, the change in sleep pattern, the heightened perception of pain, the apathetic withdrawal, the sickness behavior, she calls it. These are all induced by inflammation, and yet it is the constellation of symptoms that we can also call depression. So she's right away belling the cat and letting us know that this is a common dilemma. She said that depression is frequently comorbid with many inflammatory diseases. It's increased inflammatory biomarkers, and we're going to talk about some of the biomarkers. This is a scientific article. These are associated with major depression. For example, the cold reactive protein is something that I measure in veterans who have a stress-related disorder from war, post-traumatic stress disorder, and they have a cold reactive protein elevation. We also have done steroid studies, cortisol suppression studies, and the body that is stressed does not suppress. So these are markers that are out there, can be measured. Exposure to immunomodulating agents may increase the risk of developing depression. So sometimes people who are being treated with interferon, for example, for hepatitis C, then they have a higher risk of depression. And there's a warning that it may even be associated with suicide. COX-2 inhibitors, something that we use for anti-inflammatory care, they have warnings about this. Likewise, even taking antidepressants, there are warnings that may induce suicide. So we have to think about a lot of these things, the comorbid states back and forth. Stress can activate pro-inflammatory pathways. So a lot of people who are stressed who don't have an inflammation at first look like they do. Now it comes up to be another thing. Cardiologists have talked about this and said, well, we don't want inflammation of the heart. We don't want people to get carditis, endocarditis. So why don't we just treat them with an antibiotic course every year, just to be sure, just to get rid of inflammation. And that's debated. Certainly dentists, if you go in to see your dentist, you say, I'm going to have dental work, I have a bad cavity, it hurts, and so forth. The dentist is giving you antibiotics before you get your procedure, so you don't seed the infection throughout the body. But people tell me, as they go through that process, that they feel better, even before the dentist operates on them, fills the cavity, drills it out, so forth. They feel better just taking the antibiotic. So there's a connection that Maria's going to get at here. The antidepressants, of course, can decrease inflammation, so that's a good thing. I remember this surprised me when the H2 blockers came out, like Tigamet for the ulcers, and it's a great medicine, and other H2 blockers are out there now. But there was a medicine called doxepine. It's an antidepressant. It was as effective in treating ulcers as the H2 blockers, an antidepressant helping an inflammatory condition of the stomach. And inhibition of inflammatory pathways can improve the mood. So we can go down this in different ways. Maria, to paint the picture, states that nearly 1 person in 5 with a cardiovascular disease experiences a major depression. And we see that all the time. As a doctor, I'm called to the bedside of someone who's in the hospital, who's had a heart attack, and they're feeling discouraged, they're feeling depressed, feeling hopeless, and it's related to their heart disease, and so they come together. It's not uncommon. I've seen people, even gallbladder disease, the consultation because they have a depression that develops after their gallbladder surgery. These things happen, comorbidities. 1 in 5 is not an uncommon number. Up to 70% of the people with autoimmune diseases have a depression. So the people with rheumatoid arthritis and diseases like that, or systemic lupus and so forth, have depression. 70%, quite a high number of a correlation. And so other diseases like this, being 25% of the people with cancer, I mentioned this earlier. So the role of inflammation and its markers. Well, there's a lot of these, and they're changing, and we discover more of the markers all the time. Interleukin, tumor necrosis factor, cytokines. These are all names, and you may want to go in and read the article, and it may be beyond the scope of a half-hour discussion to talk about these in detail. But we're doing lab tests. We're looking at these markers more and more often. Used to be, it was very easy. Someone come into a doctor's office to be treated for a sore throat. You know, you might do a swab and see if it's a bacterial infection or a virus, and you might do a blood count or something and then treat it. We now do more extensive lab almost on every case, and we're looking for not only is it a virus, but then what strain of virus, what's going around now, you know, and we try to guess. We try to figure out educated guess at the next major flu epidemic. What 3 viruses do we want to protect against next season? And doctors are researching this all the time. So it's gotten very sophisticated in how we approach these markers. The cytokines, Maria wants to emphasize this in particular, and it's linked to depression. So this is something that we can look at in multiple sclerosis, horrible disease. I remember when I was in medical school, one of my first patients that I examined, we would have patients that we would go to the bedside and do an exam, and these were hospitalized patients. And I was asked to assign to a young lady, and she was probably about 16. She had multiple sclerosis. She was already bedfast, and she was on our pediatric ward at West Virginia University. And oh my goodness, my heart went out to her. And of course, I did my exam, and she was very cooperative and appreciative, but I could see the devastation of a disease like that. And people, again, with multiple sclerosis have a high rate of depression. So all these cytokine markers show up in various diseases like this. Now, let's talk a little bit about stress, because this is a big issue. We're in the summer. Hopefully you're taking a vacation. We need to, of course, always be eating our fruits, our vegetables, getting our exercise, getting our rest. But we're made to recharge our battery in various ways, and stress will lead to disease. We can extend ourselves beyond our capacity to rejuvenate ourselves, and then we end up sick. We pay a price for that. This has been looked at in various ways. Fascinating to me that we need to get so much sleep in a lifetime. It probably is about 9 hours. The average West Virginian is only getting 6 hours and 40 minutes, recent studies. So we're sleep deprived across the state of West Virginia. We're working 2 jobs. We're single mothers raising a family, various reasons why we don't get enough sleep, but we pay the price. And it looks like we need to sleep so many hours in a lifetime, and people who are good sleepers live longer. We have in the newspaper from time to time, I think this week I saw 2 people who are turning 100 in our community of Buckhannon. And happy birthday to them and to those, and congratulations to their families. But if you ask them about their sleep pattern, you'll find out that they're pretty good sleepers. And they balance their life in other ways. So we know stress and inflammation go together. We know that stress and depression go together. And of course, the greatest marker there is, of course, the war stress or the mine disaster stress, or the fire stress. If there's a flood stress in West Virginia, people who go through things like this can have post-traumatic stress disorder and end up with inflammations also. The glucocorticoid response is thought to be important in that one, and Maria highlights that in the article in Current Psychiatry. You may want to go again to that currentpsychiatry.com, volume 12, number 6, June 2013. Look at Maria Almond's article in more detail about this. There's shared pathways. In other words, the body has various ways that it handles stress and disease and inflammation, and some of the pathways are shared. There's 4 ways that the cytokines are shared in the nervous system. First of all, there's the activated primary afferent neurons. Interesting treatment for depression now is the vagus nerve. The brain, the swallowing, if you get a frog in your throat as you're stressed out, trying to give a speech or something, your heart skips a beat when you're in love, or you're anxious. You get a lot of stomach acid when you're upset. All that's the vagus nerve, the 10th nerve. And there's a treatment for this. Primarily the ear, nose, and throat doctors are doing this. They're putting a little electrode on the vagus nerve, usually implanted into the neck area where the vagus nerve is easy to find for the surgeon. And people wear a little battery pack, and they activate the vagus nerve, reverse the pathway up to the brain every day, and it's a treatment of depression. Interesting, isn't it? So the vagus nerve is one of those connections of both ways in stress and in inflammation. A lot of inflammatory diseases, a lot of the ulcers. You go back and you find that the root of that is an inflammation, but it's all tied together with stress. Cytokines released macrophages, and these are sort of the garbage cleanup cells of the body, and they're available, and they're released under circumstances of stress and inflammation. The cytokines can activate receptors to the perivascular macrophages, the endothelial brain venues, and release prostaglandin. Prostaglandin is found even when a woman is giving birth, labor. We call it labor, don't we? And certainly it is to women who go through that process. And mothers forget that pain after it's over when they see their baby, or the story is they forget it, but certainly it's worth it to them. But anyway, prostaglandins is something you can measure in that process, and it can be involved in depression also. And then there's the cytokine interleukins. So these are pathways that Maria talks about. The end result of this is that we need a lot of serotonin to feel at peace. And you go down one of these other pathways, you end up with less serotonin, and you end up with N-methyl D-aspartate, NMDA, and quinolinic acid, and these are things that the body shows as products when we're depressed, we're having inflammation. So the pathways overlap. Another issue, Maria's article is just filled with good things, and as a dad, I'm very proud of her for writing this. I'm very proud that she's a doctor, that she's a psychiatrist, and that she's brighter than I am. So all these things are great to have a daughter like Maria. But this is a good article, and I think it impacts the way we live and some of the issues that we deal with. It's inflammation and depression going together. The antidepressant effects, I've mentioned this. If you begin to treat a depression, people will then have less infections. Or if people are getting depressed, they have more infections. All of us probably have about 6 infections a year. You may want to keep track of the next year and see if you have 6 minor infections. Maybe you get 12 days of sick leave, or maybe once a month sick leave or something at work. And check out how you use those. We get an infection, we build up an immune response, keeps us from getting other infections. The immune response goes down over time, maybe in 12 weeks or something, and then we get another infection. And these are usually minor, usually viruses. But people who are sick and tired of being sick and tired will have more inflammation, and they'll have more infections, and they'll be getting depressed. And when you treat them with an antidepressant, then they improve not only the number of infections, the severity of infection, but also, of course, they feel better. They're not as depressed. I mentioned different things. I don't want to go over all the drugs that you can use to treat for inflammation, but just think about aspirin, baby aspirin. We take that 1 a day. I take it as a preventive measure for my heart, keep the blood flowing, and since it's heart disease and stroke are still major causes of death. I was at a meeting yesterday realizing that in Upshur County we are very, very high in our death rate and our incident rate for heart disease and stroke in Upshur County. Very high. I think it was 6 out of 55 counties. So in West Virginia is one of the sicker states. We're the 3rd most obese state. We have the 4th most diabetes, and on and on and on. You look at the problems that we have in health in West Virginia, but you can trace them back in part to markers like you would find in depression or inflammation. And which comes first, the chicken or the egg? That's what Maria's article is all about. But anyway, aspirin is something you can use as a preventive care in heart disease, and I certainly take my 81 milligram aspirin. Don't take it unless you ask your doctor first, but it can be treatment for inflammation. And having read this article, I would wonder if I were having trouble, if I were treating a patient and they started their Prozac, say, very common medicine to prescribe for depression, and I expected them to be feeling better in 3 weeks or 4 weeks or 5 weeks or 6 weeks. In that window, expected them to feel better, and they weren't feeling better, then maybe I would, as an adjunctive program, I would add a baby aspirin to the regimen. And based on the science of this article, it might help. Not guaranteed, but it might help, and that would certainly be something that we could look at. So we can enhance depression treatment that way. What are some future clinical implications? Maria's summing up her article in that way, and I think I'm balancing out the time pretty well here. The association between depression and inflammation raises the possibility of future theories and treatments, Maria says. So at least in a limited group, we should intervene. When people are feeling depressed, we should look for the other disease that they may have. This would be an early marker for other diseases, such as a cancer. Certainly, people can be encouraged to balance their life and try to treat their depression with lifestyle change, get lesser of their stress factors. We might do some of these markers. They're available in laboratories and look at and see if they're high, see if there's C-reactive proteins high, as it is in PTSD patients I'm familiar with, and see if it improves over time. Even Maria says in treating with electroconvulsive therapy, which is a major treatment for depression, that these biomarkers, if they're elevated, they return to normal as that therapy works. So these things fit together like a hand and a glove. Psychiatrists seeing patients need to think about inflammation. Family doctors, internists, pediatricians seeing patients treating inflammation maybe first need to consider treating a depression or looking at lifestyle issues. Fascinating article, isn't it? Depression and inflammation. This would lead me then to, and maybe a summary way, to come back around and think about how should we live. All these things are things that doctors are interested in, doctors and patients together. So first of all, you want to form a relationship, a long-term relationship, a doctor-patient relationship with someone that you can trust. We need to have that. We're fortunate in our community to have a number of family doctors, a number of internists, a number of pediatricians. I mean, I suspect there's a match. Everyone could have a primary care doctor. Certainly with the Affordable Care Act, as it unfolds, we don't know exactly how fast that will be, but even people without insurance, which might be 19% or 20% of our population here in Upshur County, will have an opportunity to have a doctor-patient relationship. We right now have community care clinics based, say, out of Rock Cave, and they're affordable through federal grants, even for people who can't afford or don't have insurance. So first of all, the urging of that relationship, because you're going to have health care events over your lifetime. I've suggested 6 inflammatory responses every year. It's not uncommon for people to go through several major depressions in a year that's stress-related, and probably change jobs at least 5 times in your career. People are going to have major events in their life, pregnancies, taking on responsibilities that can be overwhelming at times. All these things are things you can work on with your doctor. Fascinating topic. The other thing would be to think about church. People who balance their life and include worship of God. I'm not saying Catholic, Jewish, Protestant, even Muslim. I'm not saying that one is better than the other when it comes to health measures. But the studies have been done at Duke University and then replicated at other universities, that if you worship at least twice a week, that you'll be healthier. You'll spend less on your health care over your lifetime. Over a lifetime, people who worship twice a week would live about 10 years longer than people who don't, for various reasons, balancing their life, maybe inflammation, whatever it is. But that's another lifestyle habit that we would promote, especially through our program, Tender Loving Care. Well, until the next time, this is Dr. Greenbrier Allman thanking you for joining us on our program, Tender Loving Care. Special thanks to Channel 3 for this opportunity to come your way each week. Look forward to other topics of interest, and of course, I'm proud of Maria Almond, Dr. Almond, the psychiatrist, and the doctor talking today about inflammation and depression.
Stories of a West Virginia Doctor, written by Dr. Harold D. Allman. A collection of 55 short stories about his experience as a small-town doctor in central West Virginia. And Tender Loving Care. Stories from a West Virginia Doctor, Volume 2, written by Dr. Greenbrier Allman, using videotapes to write 70 additional stories of his father's very colorful life as a small-town doctor. They can be found for purchase at Amazon.com and most local bookstores. Tune into Channel 3 Buckhannon for Tender Loving Care with Dr. Greenbrier Allman, where he talks about the connection between Christianity and medicine.